Excellent. Thanks again, and thank you again for your participation. And we need more actually of your questions and comments because we're here to share experience. So what I'm going to do over the next 10, 15 minutes is I'm going to talk about what you really need to know about the 2021 international guidelines on urticaria. But before doing that, the international urticaria guidelines have undergone really numerous revisions over the years and updates. And the first guidelines on urticaria was about 22 years ago in the year 2000. And that has had sort of a number of revisions, updates, elimination of certain recommendations until the mostly recent published guidelines, which were revised and updated and published in September 2021. So the current guidelines were the result of the outcome of the 6th International Consensus Meeting on Urticaria, which was in Berlin in December 2020. What is different about this guidelines is that it has included other societies and subgroups from all over the world. So we have the IACI is represented there, the European Academy of Allergy and Clinical Immunology, GALEN, this is the academic part of the IACI, which is the Global Allergy and Asthma European Network, and its UCARE and ACARE centers, the European Dermatology Forum, and what's new here is the involvement of the Asia Pacific Association of Allergy, Asthma, and Clinical Immunology. The panel, there were about 64 urticaria experts from 31 countries, and these panelists were nominated as delegates by 50 national or international medical scientific societies. So really, it's a global and international panel who was leading the urticaria guidelines. Now, I was privileged to be part of this panel, and the guideline coordinators were Professor Marcus Maurer and Professor Zobrier, and I'm sure you've either met or have heard of these people, these two names, and actually these two guys have done a lot in the urticaria field. Marx was the driving force behind making Xolair available for urticaria. This guy has done extremely, a great job, and he's continued to lead the forefront of urticaria management, and he's involved in lots of studies, etc., etc. So I'm not going to dwell on things that have been mentioned before, but anyway, like any disease, when you're putting in guidelines, you have to define that particular disease. So here, the definition of urticaria is, as you all know now, is a condition characterized by the development of wheals or hives, angioedema, or both. So the spectrum of the urticaria actually includes angioedema as well as hives, if you like. Now, again, the recommendation here regarding classification, as has been mentioned by the previous speakers, into chronic and to inducible urticaria. And again, I'm not going to go into a great detail. So we have the chronic and the inducible, and this recommendation of classification has been there for many, many years and hasn't changed. And again, why do we, what's the aim of the diagnostic workup in patients? And again, like Dr. Hamili had mentioned, we need to confirm the diagnosis, we need to find causes, cofactors, comorbidities, quality of life and consequences of urticaria and angioedema components, and of course, the course of the disease monitored regularly. Now, this is very important. I'm not going to go through it because it's very comprehensive, but I just wanted to draw your attention to the differential diagnosis there. So we need to make sure that the patient, so not all hives or swellings are related to chronic urticaria and angioedema. This is not the case. We have to make sure. I'll come back to the acquired and hereditary angioedema in a minute. but we need to make sure that the urticarial vasculitis is ruled out. We need to make sure that chronic, HAE, the hereditary angioedema has been ruled out. Now, this is very important, and I think I need to spend a few minutes talking about this issue, because in the Gulf area, we have about 400 patients of hereditary angioedema. Given the population, we should have about 4,000 patients. Where are the other patients? So we're only identifying a fraction of what we need to see. So I'm sure they're in the community somewhere. So we need to identify these patients. And the difference between an angioedema related to or part of the spectrum of chronic spontaneous urticaria angioedema and hereditary angioedema is that the swellings in angioedema, for example, hereditary type, takes longer than 24 hours. It takes up to 3 to 5 days to develop fully, and then another few days to resolve. So it is really important to take history, like Dr. Hamdi said, spend some time to make sure that what are we dealing here with? Is it angioedema due to part of the spectrum of the chronic urticaria, or is it hereditary angioedema? So I'm sure we have lots of patients that that are in the community. We're not picking them up. So just bear that in mind. Angioedema, hereditary angioedema, is really an important diagnosis not to miss, because if you missed it, then we have lots of patients will suffer the consequences. And I can tell you stories about this. I mean, I had a patient with another patient who, and by the way, this is not it's hereditary. It doesn't mean that the patient will develop it in a younger age. We had patients who are presenting for the first time as an adult. And we have a published case report about a patient who actually presented with hereditary angioedema around 20 years of age. And he was treated with Xolair for a year because he had erythema marginatum, like Dr. Ravi said, and he had this swellings, recurrent swellings, and he was given a Xolair for 1 year. Of course, it didn't really touch his angioedema or urticaria. So it is really very important. And I'm sure the patients with swellings will come to your practice. So please do not miss that because it's really a very important, and it is a life-threatening condition. This is where patients can actually die from it. So as I said, this is an interesting algorithm, and you can look it up in the publication there. So again, we need to consider the differential diagnosis. We should consider the differential diagnosis in all patients with signs and symptoms of chronic urticaria based on guideline algorithm. And there is a 100% agreement between the panels that we should do that. And as I mentioned in the previous slide, that we need to differentiate the chronic urticaria from an angioedema from other causes of swellings and rashes. Routine diagnostics in chronic urticaria, we really recommended a limited investigations, basic tests, including, like what Dr. Mohamed said, CBC, CRP, and in specialized care centers. They talk about total IG and anti-TPO antibodies and other more biomarkers as appropriate. And again, you see here, specialized care centers. So not everybody shouldn't do, a plethora of tests unnecessarily on these patients. So again, be limited in what you do for your patients based on history, and you do more according to the history. For CIndU, what do we need to do? We need to, and again, this is very interesting because there's a more than 90% agreement on this. So we recommend using provocation tests, like Mohamed mentioned, to diagnose chronic inducible urticaria. Provocation tests, threshold measures, and UCT measure disease activity and control in patients with CIndU. So that's really very, very important as well. Now, again, I'm not suggesting that every center would have, a TIMP test or, go into these sophisticated tests. No, I mean, as I said, if you have a patient you're struggling with, we're always there to help, and we're in the background, and we can share patients and vice versa. So it is important in CIndU to identify the trigger as much as possible, And this is the recommendation from the guidelines as well. Now, again, the urticaria activity scores, and the angioedema scores as well for assessing disease activity. Now, some of these scores are cumbersome. I mean, and they're not and can be used in clinical practice, on daily basis. We see lots of urticaria patients. I mean, our 15 to 20% of our patients attending Cleveland Clinic allergy immunology are chronic urticaria, and we're busy. I mean, Mohamed and I would have 3 patients in one slot, or in one time. So we can't do all of these, but try and find a measure. These are good utility scores. Try and develop your own. We use the UCT, or the urticaria control test, which I've translated to Arabic, and I can share it with you if you want. It's been published, and it's a very good, like the asthma control test or the ACT test, which gives you a very clear cut on the patient's, urticaria control, etc. So it is important to have some measure that you can do in clinical practice. But again, a lot of these tools are good. Some are cumbersome, like patients, and patients really don't have patience to fill in these forms. But I think the UCT, or the urticaria control, is a good way of measuring disease activity in these patients, or disease control, if you like. So the guidelines recommend using a measure to assess disease activity as well as control. Now, again, this is we try to mimic the GINA guidelines here. So, the aims of treating patients with chronic urticaria is to assess. You have to assess the patients. You need to do diagnostic procedures. You need to identify comorbidities. You need to see or allocate, severity scores like the UCT, patient preference, side effects of the treatment. Then you act. They need to modify treatment, at non-pharmacological interventions, educate the patients, and then you adjust. So if the patient gets better, then step down maybe if control is adequate, step up if the control is inadequate. And again, we suggested that the urticaria control score maybe is a good way, easy way to use. And as I said to you, I'm emphasizing this point. If you need it, just tell me, and we'll send it to you, and you can use it in clinical practice. So again, like it's been said before, there are a couple of questions, and the cutoff is 12. So anything about less than 12 means that the patient is not controlled, and then you can step up your treatment. Well controlled, 12 or 15, continue therapy and try to optimize, and then above 16, this is complete control. You can step down this way. So this is, as I said, that's what we use in our clinics. Now, modern second-generation antihistamines. Now, this is really, the question was, should different second-generation antihistamine be used at the same time? And the answer to that is no. So there is no need to mix antihistamines. Just stick with one, use high dose of one antihistamine. So there's no need, and there's no benefit. And this is based on clinical experience, and you can see there is more than 70% agreement on this point from the panelists. And in my view, and I think this is shared by others, is that there's no point in mixing. Some patients may be helped by mixing the antihistamines, but overall, there's no need. You can go up to 4-fold of one single antihistamine, and this is, again, that's what the guidelines say. If there is no improvement, should higher than 4-fold doses of second-generation antihistamines be used? And the recommendation is that using higher than 4-fold antihistamine is not really recommended. But I have patients who use up to 6-fold of a particular antihistamine. But generally speaking, we don't recommend using antihistamines more than 4 the recommended dose, or more than 4 the standard dose. Now, this is really very important. I wanted to concentrate on this, because the changes have been made on this on the treatment algorithm. So the treatment algorithm says, this is the current one compared to the past guidelines. So start with your standard dose of second-generation antihistamine, increased the dose up to 4 folds. That's no issues there. In the past, you need to wait for 8 months or 8 weeks. So 8 weeks, and then you move to omalizumab. But here, we decided that 2 to 4 weeks, 2 to 4 weeks of using the high-dose antihistamines or earlier. So you don't need to wait actually for 4 weeks. You don't need to wait for 2 weeks. But if the patient is really not responding, you can then move into the second generation or the second way of adding omalizumab. So omalizumab can be added actually after 2 to 4 weeks or earlier if the patient is not really controlled on high-dose antihistamines. Now, if the control is not adequate, and you can move on to cyclosporine, for example. You can within 6 months. So you have to tell your patients. This is really important because the patients come to our clinic saying, "Look, doctor, I'm okay now. I thought it was 1 dose and I'm done." No, I think you need to continue for at least 6 months. I tell my patients, look, be prepared for the long haul. You're going to take Xolair for at least a year, 6 months to a year, just to prepare them, because some patients, you'll see in our study later on, will not respond from the first dose. You need to keep at it, and you need to give at least 6 months to a year. So this is really very, very important. Okay. Now, if there is no adequate control with omalizumab, you can wait for a few months, and then if no control, then cyclosporine or any other immunosuppressive agent. There are lots of immunosuppressive agents like cyclosporine, like colchicine, dapsone, etc., you can use. But here we recommended that if no response after omalizumab, move on to cyclosporine. Now, what we recommended is that 300 milligrams every 4 weeks, and this is the standard. But what is new is that you can actually use up to 600 milligrams. Okay, and 600 milligrams can be used, and I've used it in certain patients, and with varying effect. Actually, it doesn't mean that the patients, if you give them high Xolair, then they improve. But we've tried 600 milligrams and with variable response. Now you can go up to 5 milligrams of 5 milligrams per kg for cyclosporine. In the past, it used to be 3.5, but now you can go up to 5 milligrams. So these are the changes, and there is a case for giving a short course of steroids. Now, be careful. I'm not saying that you need to give patients short courses of steroids, all the time. No, short course of steroids. You can treat your acute on chronic patients with a short, course of steroids if needs be, but do not use steroids for longer than a few days, because what happens is that patients improve, but the problem comes back with a vengeance. Okay, so when you stop the steroids, urticaria can come back with a vengeance. Similarly with high-dose antihistamines. So if you give high doses antihistamines more than 4-fold, actually urticaria can get worse. So be aware of that. Okay, so I think this is the last slide. Any questions or comments on what you've heard so far? There's no real. We don't have evidence of saying that's the case, and we don't recommend using singular. But again, these are based on your experience. But we can't in the guidelines. There's no evidence that singular works. Doesn't work. Certain patients might improve, but it doesn't work. That's what I normally do. I don't start Xolair immediately, but the guidelines say, well, look, if your 4-fold antihistamine do not work, you can use your Xolair. But in my view, again, this is guidelines remains a guideline, So I think what you need to do is you need to use your judgment, because patients sometimes they can't afford omalizumab, so you need to give something else if they don't respond to high-dose antihistamines. And the guidelines say don't use two different antihistamines, then what you'd use? Doxepin is a good way of treating these patients as well. So it's good. Yeah. I use 10 milligrams at bedtime, but you can use up to 100 milligrams a day. Do you find it? Is it available? I thought that it's not available until it's a Cleveland. Yeah, because I remember when we set the service, I asked for it to be available, and it's not available elsewhere. Yes, correct. Yeah, I can't hear you properly. So. Correct. Correct. You can. You can add it as we said here. Increase dose or and you can add, yes, you can add second generation HA cyclosporin. Yeah. You can, and that's what I do. 3.5. I used a small dose and then I increase it up if the patient is not responding. Yeah, so you can use that. Yeah.
You mentioned that you use this tablet in some patients. You use this tablet and is it like insurance issue that?
I'm not saying you use 6 tablets. No, I'm not saying that. I said some patients have used 6 tablets. The upper, yeah, with the fourfold is your max. Anything above fourfold is not recommended. But some patients, some of my patients have used even 6 tablets of cetirizine. No, because it's readily available. They don't need to. They can buy it over the counter, or if you give them higher, more tablets, they'll use that instead. So, but it's not recommended. The guidelines say fourfold only. Now, for all antihistamines, not only cetirizine, you can do that for fexofenadine as well. Mohamed.
What's your view on mixing antihistamines? For example,
you weren't listening because you were talking to Ravi. The guidelines say no, do not mix. Okay, so this is it. Here we are. So should different 2 generation antihistamines be used at the same time? Yeah. We suggest against using it, and this is 70% consensus.
That's European. Problem is, some of the times the flexibility, you won't see QT problem. Reach 4 times the dose. And we are changing a lot of work, we don't want to do it, and we end up something like that. So this is the reason why if you look at North American guidelines, they don't recommend you beyond 4 times the flexibility. However, there is no such contraindication with cetirizine or Loratadine. So we are okay with 4 times the dosing of those antihistamines. But flexibility, I think, beyond twice the daily dosing is kind of required. And one more thing is when you're doing cetirizine or Loratadine and this comorbidities of hypertension and all that, CKD, then we look from the renal standpoint. So this is quite extensively looked in American chronic urticaria practice guidelines. And some of the practical reasons because we started about the mixing of the day. However, in Europe, we take one antihistamine in Europe and we are looking at it for cetirizine and Loratadine as long as there is no renal dysfunction or capital dysfunction. However, fexofenadine and I think the latest results to advise caution because as you go to higher doses, you're going to come out. And if there is any underlying rhythm, my understanding, they want to exacerbate. So just keep this to that level.
Two to 4 weeks, according to the new guidelines. 2 to 4 weeks in patient. You taper down. Exactly, taper down. Because these patients will come back to you. Taper down. If they it's for no, you can increase patients. Again, you have to discuss this with patients. You have the liberty there to increase up to 4-fold or to move to omalizumab. As I said, the new thing here, the advanced recommend. I think this is an important algorithm because all the time we've used that. We've said that omalizumab is a very safe medication. Use it, and there is a reluctance of using omalizumab because I think, in my view, omalizumab is really meant for urticaria discovered first in asthma. And if you look at asthmatic response to omalizumab compared to the urticaria, I mean, about 65 to 70% of patients with asthma respond to omalizumab, where up to 95% of patients with urticaria would respond. So it's a very safe medication. We've given it now. There's a data to be given even during pregnancy without issues. So it is safe. So you have the liberty there of moving. it depends on the patient's background, depends on the patient's affordability as well, because remember, Xolair is not cheap medication. Exactly, exactly. So the fourfold is based on one antihistamine. But again, as I said, guidelines are guidelines, and it's your clinical practice. You can talk to the patient. Sometimes I do give non-sedating antihistamine during the day and a sedating antihistamine at night, and so on. So it is, but if you go back to the guidelines, you know, it's just, and again, this is the experience. It doesn't really show that, you know, mixing is really unimportant or it's of any value. Any more questions? No, because it takes a while for cyclosporin to work. So I wouldn't give cyclosporin. No, cyclosporin is at a later stage. Now, antihistamines usually push the antihistamines all the time with a bit of maybe if it needs me, a short course of steroids. But I mean, again, I'm against using steroids in chronic urticaria. That's what we teach our ED people not to give, because the problem is when you stop it, it comes back with a vengeance. It becomes more severe, and you end up with patients, yeah, doctor, coming back and it's more severe, etc. So I try not to. I said to the patient, look, persevere with it, it will disappear. Take your antihistamines and it will go away. So no, cyclosporin, don't use it as an acute treatment. Yeah. Good. 20 minutes, 20 milligrams for 5 days. That's it. That's it. You can stop, no tapering.
So I wanted to comment about the steroid usage perhaps so can we look at the published the lack of which inspired us the substance and what did I learn from my first patients? So interesting observation he made was low dose of corticosteroids were giving the same benefit as high dose corticosteroids. In a dystopic disease model, as an escalated steroids, there is dose response, there is pattern. In the mast cell-based urticaria disease model, there is no dose. The low dose will do the same job as high dose. Unfortunately, in the emergency application, we are used to giving very high dose, expecting that rapid improvement will be, but the low dose will do the same job. So the very severe facial capital and some of those negative already comes with those sleep. And the more higher dose you do, the more you know faster activation is going. So probably that's something we need to kind of keep in the back of mind.
Okay, thank you.